Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning. Today's lecture is about diagnosis and staging of colorectal cancer. I'm Mosab Shetiwy, lecturer of surgical oncology, Oncology Center, Mansouriya University. In today's lecture, you'll learn the clinical pathological staging of colorectal cancer, typical and some unusual presentations of patients with colorectal carcinoma, and how to approach a patient with suspected cancer. Let me remind you that colorectal cancer is one of the big four cancers worldwide. According to 2016 statistics in the USA, colorectal cancer is the third most common cancer as regard incidence, and it's the third most common cancer causing death in both males and females. You should have learned by now in previous lectures the predisposing factors and pre-malignant lesions like colorectal polyps and polyposis syndromes and hereditary cancer syndromes that may be predisposed to colorectal carcinoma. You've had also an idea about the screening recommendations for colorectal carcinoma, like those implemented by the US Task Force. Like, for example, in males between the age of 50 and 75, they should do colonoscopy every 5 to 10 years or FET test every year. You should have an idea about risk factors that influence or may influence these screening recommendations, like the presence of inflammatory bowel disease, for example. And it's recommended that surveillance or screening for colorectal carcinoma occurs more frequently than in normal population. And you should also have an idea about the protective factors against colorectal carcinoma, like vitamin D, exercises, and the impact of aspirin and nonsteroidals like Solindac on decreasing the risk for colorectal carcinoma. Let's start today's lecture with the pathology. As for the sites of colorectal carcinoma, the commonest site is the sigmoid and rectosigmoid areas. Actually, they constitute about 50% of all cases, followed by the cecum and the ascending colon, and then the transverse colon and the remainder of the segments of the colon. You should know that synchronous lesions, which is the presence of more than one lesion in different segments of colon cancer, occurs in about 5% of the cases, while metaclonus lesions occur in about 2% of the cases. As for the rectum, because nowadays it's considered a different organ than the colon, it should be described differently because it shows different clinical presentation and its approach to management is also different. So as for the incidence of rectal carcinoma, fortunately, alhamdulillah, 70%, that's most cases, a majority, occur in the upper third of the rectum, rectosigmoid area. About a quarter occur in the middle third of the rectum, and the lower third shows about 5% of all cases. So let's get into more depth into the pathology of colorectal carcinoma. Actually, the lesions may present in different patterns. The pattern depends on the site of the tumor. Right-sided lesions tend to be of a polypoid or cauliflower masses, or large fungating masses on the right side. More commonly, the left side of the colon tends to harbor ulcerative lesions, and should know the criteria of a malignant ulcer, which is raised everted edges, necrotic flora, and indurated base. Other types or patterns of colorectal carcinoma actually have grave prognosis or worse prognosis, like annular or stenosing type. This type develops from a malignant ulcer. It bores or extends through the tumor wall and gradually extends inside this wall circumferentially to completely obstruct the lumen if untreated. And it's said that it takes about 6 months of this type of annular type to traverse bowel circumference in traverse quarter of bowel circumference. so it ultimately takes less than 2 years to completely obstruct the lumen. Microscopically speaking, colorectal carcinoma tend to be of the adenocarcinoma variants according to WHO classification. It constitutes about more than 90% of all cases. Other uncommon or rare carcinoma like adenosquamous carcinoma, spindle cell carcinoma, squamous carcinoma, and undifferentiated cancer. You should know that adenocarcinoma has different subtypes. Some are of good prognosis and others of bad prognosis, like the mucinous carcinoma and signet ring cell carcinoma. Actually, mucinous and signet ring cell carcinoma are also called mucin-producing tumors. Mucinous carcinoma is a tumor that produces extracellular mucin. Mucin is a bad product from tumors that tends to traverse the tumor wall, dissects through it, and extends to the surrounding organs, so it has a power of local extension. And it's said that a tumor is mucinous when mucin comprises 50 or more percent of the tumor mass. This extracellular mucin produced gives it its penetrability into nearby organs and structures. This type constitutes about 10% of all cases of colorectal carcinoma, and as you may predict, it's of a bad prognosis, type, because it also shows poor response to neoadjuvant and adjuvant chemoradiotherapy. As for the signet ring cell variant of adenocarcinoma, this variant of mucin-producing tumor produces intracellular mucin. Intracellular mucin pushes the cells into the nucleus inside the cell into one side, causing vacuolated cells or empty-like cells, like the ring. So that there comes the name from these cells. Signet ring cell carcinoma, which uses intracellular mucin, and it's, as you may predict, also an aggressive variant because it has a propensity for extensive intramural spread and peritoneal carcinomatosis. As for the grading of colorectal carcinoma, tumors of low grade are or have the most developed glandular structures with least mitosis, like in G1 photo, upper left photo, and tumors of high grade or high grade tumors tend to have least developed glandular structures and highest mitosis, and thus highest multiplicity and replication, like in G3. They no longer resemble the normal architecture of the glandular structures of the cells. So grading depends on the degree of formation of glandular structure, because you're talking about adenocarcinoma or glandular tissue, nuclear polymorphism, and number of mitoses. There's another staging, the broader staging, which is a little bit different. It's a two-tier system based on the gland formation only. If less than 50% of glands represented inside the slide or in the section that is cut from the tumor, then this means that it is of a high-grade disease because it has least developed or less developed glandular structure. So this is a poor or undifferentiated tumor. So actually, broader staging is nowadays is being adopted because it divides tumors into either well or moderate differentiated tumors or poorly or undifferentiated tumors. I mean, into two categories rather than three categories. As for staging of carcinoma follows worldwide the T&M, as you've had previously in the breast, and you'll see later in head and neck carcinoma or other GIT cancers. Anyways, as for colorectal carcinoma, they have two other staging systems that were adopted and still being adopted in many centers like ours. Dukes and Astracola. Let's start with the Dukes and its modification. Dukes actually is a pathologist. He was a pathologist in St. Mark's Hospital in London. In 1932, he gave these three stages, A, B, and C. He staged colorectal carcinoma as A if the colorectal cancer invasion doesn't extend into the muscular layer of the tumor wall, يعني it just involves the mucosa or submucosa. Stage B colorectal carcinoma, according to Dukes, involves the musculosa or muscularis propria, but not involving lymph nodes. And lastly, stage Dukes C is where lymph nodes are involved. Dukes died actually for describing stage D disease, and they later added this stage D, to describe metastatic disease. Aslacolla is the same as Dukes. It's actually a replica of Dukes staging. This is the MAC or modified Aslacolla, where stage A involves only the mucosa. Stage B extends beyond the mucosa and subdivided into B1 submucosa or musculosa, B2 into the serosa, and B3 through the serosa and visible peritoneum into adjacent organs. As for the lymph node involvement, if any of the three subgroups of B is associated with lymph node spread, then it will be a stage C, either 1, 2, 3. And stage D marks distant metastasis. It's easier than the T and M. Most instances, this Aslacolla and Dukes, so some institutes still adopt this system for staging. But worldwide, the American Joint Committee of Cancer proposed this T and M staging system, and it's being revised yearly or even more than one time every year. So this is the last version of the T and M. As you know, T is a tumor. If it is an in situ or intramucosal epithelial carcinoma, this is a TIS. A T1 tumor is the tumor that extends through not just the mucosa but also into the submucosa. T2 tumor extends into the musculosa. T3 into the bilicoelic fat. T4 into either adjacent organs, T4B, or just the visceral peritoneum, T4A tumor. As for the N, the lymph node staging, and 0, no lymph nodes affected. N1 means metastasis in 3 or less lymph nodes regionally, and N2 is metastasis in 4 or more lymph nodes. The M denotes distant metastasis for colorectal carcinoma. M1 means positive distant metastasis. It's subdivided in the last version into 3 categories. M1A is a metastasis confined to one site or organ like liver, lung, or ovaries, but not the peritoneum. M1B involves more than one site, but if the peritoneum is infiltrated by a tumor, it is staged as M1C because it is of the worst prognostic factor amongst the 3 subtypes of this M stage. I'd like to remind you of these words. The C, T, and M means clinically adopted T and M, which can be adopted by examination and by after radiologic investigations. That's a preoperative staging, actually, the C, T, and M. You may be confronted with it during the clinical rounds or in the outpatient clinic while we are preparing patients for admission. The next is the PT and M, which denotes the pathological T and M, and this is exclusively written in the pathological reports of postoperative specimens. Y, PT, and M is where we add a Y when the patient receives neoadjuvant chemotherapy and he undergoes surgery, and this is also exclusive for pathological reports. And this refers to the importance of telling the pathologist that the patient receive neoadjuvant chemotherapy, because he might see these effects in the pathological specimen after resection. And RTNM is the recurrent carcinoma, or denotes recurrent carcinoma after a period of disease-free survival. So in short, as in all of the TNM staging classifications, all the preoperative workup and intraoperative findings are used to assign a clinical stage, CTNM. But BTNM is exclusively for gross pathologic or histopathologic examination. Well, actually, staging of tumors by TNM or Dukes or MAC is further classified into this table into stages 0, 1, 2, 3, or 4. Stage 0 is a TIS carcinoma. Stages 1 and 2 are node negative. Stage 3 is node positive cancer. Stage 4 is metastatic disease. Well, actually, this is a very big table. I personally cannot memorize this table, so this is the short form of the previous table. As I mentioned, stage 0 is an in situ carcinoma. Stages 1 and 2 are early node negative carcinoma. Stage 3 is node positive, and stage 4 is metastatic disease. You'll receive a lecture about the complications and how to manage these complications of colorectal carcinoma, because this might be the presenting symptom, like for example, presentation of acute intestinal obstruction with left-sided lesions, or bleeding with profuse bleeding or acute bleeding with rectosigmoid or rectal carcinoma, and so on. So as for the presentation of colorectal carcinoma, the typical age of colorectal cancer is about 50 years of age. Males are more commonly affected than females, especially those who have family history of either polyps, benign polyps, or adenomatous polyps, that is, or colorectal cancer. And it's higher in instance in Western countries because it's related to their diets, because in their diets they tend to have high fats in their diets, and that's a predisposing factor that is incriminated for colorectal carcinoma. Clinical presentation of colorectal cancer varies between suspicious symptoms and signs, or accidental discovery on routine screening of asymptomatic patients, or as we've mentioned before, complicated presentation, or presentation with complication, and that is more commonly encountered in the emergency hospital with intestinal obstruction, perforation, and peritonitis, or rarely acute bleeding. So symptoms may occur because of the effect of local effect of the tumor, or the effect of metastatic disease, or there may be some unusual presentations. So let's take an overall view of typical presentation of colorectal carcinoma. 3/4 of the patients present with change of bowel habits. About half of them will be having the most common symptom combination, which is bleeding per rectum and change of bowel habits. Rectal mass is commonly seen in rectal carcinoma, and that is in about 1/4 of the patients. 8 of the patients will present with abdominal mass, so it's an uncommon finding or presentation that the patient will be having an abdominal mass, so don't expect to an examination of a patient with colorectal cancer to have to find an abdominal mass, because its incidence is about 10% or 12%. Iron deficiency anemia occurs in 10% of the patients, and they rarely present with pain. So the most common symptom will be change of bowel habits. The most common symptom combination is change of bowel habits and bleeding per rectum, and the least common combination is going to be pain and mass. According to locations, as we've mentioned previously, changes of bowel habits more likely to be on the left side of the lesion because they tend to be of the ulcerative type, while on the other hand, chronic bleeding from a mass on the right side may cause iron deficiency anemia. And as for the rectosigmoid area, they tend to present with bleeding rectum. 20% of all cases of colorectal carcinoma present with metastasis from the start. So at presentation, they tend to be metastatic. And of course, colorectal carcinoma, like any cancer, tends to spread directly by lymphatic spread, hematogenous spread, and exclusively for GIT translumic spread. So these are the different methods of spread of cancers. So direct spread for colorectal carcinoma occurs in all the planes, longitudinal spread along the lumen, transversely, circumferentially, and radially outside the wall. Lymphatic spread occurs to regional lymph nodes, which are epirectal or epicolorectal, barorectal or baracolic, and then to intermediate, and then to central lymph nodes to the around the big feeding vessels. And you should know that lymphatics of the GIT are different from lymphatics all over the body. Lymphatics all over the body, or lymph nodes all over the body, tend to follow veins, like cervical lymph nodes in the neck are found on the internal jugular veins. Axillary lymph nodes are found on the axillary veins, and also inguinal lymph nodes tend to be distributed on the femoral vein and its branches. But as for the GIT lymphatics or lymph nodes tend to follow arteries, not veins. So if you want to make sure that you have radically resected colorectal carcinoma, then you have to reach for the central lymph nodes with central vessel ligation and so on. We'll get to that when we get to the treatments. So the most common site of spread will be regional lymph nodes. But the most common site of distant metastasis through blood spread is for GIT carcinoma is the liver. And why is that? Because GIT drains into the portal vein, and through the portal circulation, portal vein carries blood that contains these tumor cells into the liver, harbor in the liver. So 30% of all patients will have distant spread to the liver. Lung is an uncommon site of distant metastasis, and it occurs mainly with low rectal lesions, because the distal rectum is drained by veins that bypass the portal circulation and drain into the inferior vena cava and into the lungs. So when we investigate a case of low rectal cancer, it's important to scan the chest for distal metastasis rather than the liver. As we mentioned, GIT carcinoma tend to have translumic spread. The translumic spread is due to subperitoneal lymphatics. The spread may cause malignant ascites, omental or peritoneal nodules, broken back tumors of the ovary, or even thickening of the rectovesical fascia, which is called the rectal shelf of Plummer, and that marks the importance of digital rectal examination and vaginal examination in cases with suspected colorectal carcinoma. Of course, the presence of distant metastasis, especially translumic spread, is a sign of grave prognosis, because actually treatment combinations of aggressive cytoreductive and surgery and intraperitoneal chemotherapy fail usually to resolve such an issue of translumic spread. So this is the most fearful metastatic spread amongst all. As for rectal cancer, as we've mentioned, the earliest and most important symptom is the bleeding rectum, usually at the end of defecation. There might be some irritative or obstructive manifestations. Irritative tend to be the lower half of the rectum, related to a sense of incomplete defecation, and the upper half of the rectum may present with some obstructive manifestations like alteration in bowel habits. Unusual presentations with colorectal carcinoma may be signs of metastatic disease. So, in examination, generally, you may find jaundice in a patient with suspected colorectal carcinoma, which may denote heavy metastatic disease to the liver or portahepatis, portahepatic lymph nodes that cause obstruction of the biliary retriever bile ducts, causing jaundice, and so on. So that's one important sign of metastasis. Another sign of metastasis is left supraclavicular lymph node enlargement. That's called Troisier sign, which also indicates metastatic disease. Locally, signs of metastasis may include systemic Joseph nodules, which are umbilical nodules, and of course, on examination, digital rectal examination and visual examination may show Douglas Fouts nodules, and ovarian tumors could be felt on digital rectal examination or on vaginal examination. Typical presentations may be the presence of malignant fistula, for example, which denotes local invasion, or pyrexia of unknown origin, or signs of metastasis of unknown primary, like positive Troisier sign, for example, or maybe Joseph nodules without any other symptoms, and so on. So there might be some atypical presentations that you should be aware of. So now it's time for some investigations for those patients who present with suspicious symptoms or signs of colorectal carcinoma. So as for the investigations, as you already know by now, we have three categories of investigations: those for diagnosis, others for resectability, and a third group or category for or as metastatic workup. As for diagnosis, gold standard for diagnosis of colorectal carcinoma is colonoscopy with biopsy. So colonoscopy would advocate introduction of an endoscope inside the lumen of the colon and rectum, and if he finds a lesion, he'll take a biopsy. So not just colonoscopy, but colonoscopy and biopsy. This is the gold standard investigation for diagnosis. Other lab tests that may be used, like fecal occult blood test, it's almost always positive for cases of colorectal carcinoma. A CBC may denote anemia, and some tumor markers that you should know of, like CEA and CA19-9. Actually, both of them are not diagnostic, they are prognostic. CEA is more important for colon carcinoma. It may arise in benign conditions. It may be high in benign conditions like benign colonic tumors, cirrhosis, or even pancreatitis. Its value is not diagnostic, it's prognostic, which means that, for example, colorectal carcinoma with very high CEA, this may denote metastasis, and its prognostic value, of course, is also regarding the recurrence. So if a patient presents primarily with colorectal carcinoma and high CEA and has been treated with surgery and chemotherapy, and the CEA returns to the basal levels after treatment, then on follow-up, on serial follow-up of this patient, later on, if CEA rises again, this will denote recurrence after treatment. So as we've mentioned, gold standard for diagnosis will be colonoscopy and biopsy. Of course, barium or double contrast barium enema is nowadays not the first investigation or tool to be used. Its use is limited to cases where colonoscopy is not available or so on, because barium is very irritant, and if the patient is perforated or suspected to have an obstruction, barium may aggravate the symptoms and may cause complications. But actually, this is the typical picture of rectosigmoid lesion or rectosigmoid cancer on barium enema. This is the typical apple core appearance of colorectal carcinoma with breasting or shouldering of carcinoma ends, mucosal irregularity and destruction in the middle. So we encounter some cases where colonoscopy fails to pass the site of lesion. So on, for example, introduction of colonoscopy to a rectosigmoid area, there is a very big fungating mass that is impossible to colonoscopy, so the colonoscope can't pass beyond this obstructing lesion. So at this time, the colonoscopy is deemed incomplete. But actually, this is not enough for investigating a patient, because there is an incidence of synchronous lesions of about 5% of all cases. So we may miss another lesion in another segment of the colon. That's why it must be evaluated all through. So when colonoscopy fails to pass the obstruction or to show or visualize the whole colon, then we should use another investigation or tool. We have actually two tools. We have the CTC or CT colonography, and this is a photo of CT colonography, which is the usual, like the usual CT, but with some addition of some software. It receives the cuts of the normal CT and forms a holographic image of the bowel from inside, and may show the other parts of the colon. Like for example, this CTC shows a polyp inside the transverse colon. Another method to visualize the entire colon when it's impossible by colonoscopy is the Bill cam. It's a wireless video colon capsule which is ingested and swallowed, and it's actually used for intestinal diseases, small intestinal diseases, because there is no endoscope that can get through the small intestine. But actually, it's also used for obstructing lesions in the colon to visualize the proximal part of this colon. So this is the view of colonoscopy from inside. Okay, and this is a lesion in the right side of the colon. On colonoscopy, it shows a huge mass, large fungating mass. It's not obstructing the lumen, but nearly obstructing it actually, and it's bleeding on touch. This is another lesion or adenocarcinoma of the colon with a variety of appearances, like in A, an exophytic mass, B, a bulboidal mass, and in C, there is a circumferential obstructing mass of the colon. The second category of investigations are investigations for resectability. For colon and rectal carcinoma, as for resectability, we offer or order a CT or MRI abdomen and pelvis to see if colonic masses, if they are locally advanced, if they are attached to a nearby structure, do we have, or is there a need for multi-organ resection if it's involving another structure, like for example, uterus in pelvic tumors and so on. And exclusively for rectum, we use for resectability either EUS or MRI pelvis. EUS is better and superior because it gives an idea about the extent of tumor invasion through the wall or transmural invasion. It gives an idea about the involvement of the sphincter, that's the internal sphincter, to guide further treatment or management plan. And it also shows the presence of enlarged lymph nodes within the mesocolon. The third category of investigations are investigations for staging. As you know, the liver is the most common site of metastasis from colorectal carcinoma. So it must be scanned previously or preoperatively with contrast CT. Um, lungs are also scanned by CT chest for especially for rectal or lower rectal lesions. Um, and there is a new PET scan or PET CT scan, which has, of course, limited indications, like localizing the site of disease recurrence in patients who have high CEA without any visualized disease on follow-up, and it's also indicated to evaluate patients who are thought to be present or future candidates for resection of isolated colorectal liver mets. So its routine use is not actually recommended. So that's the end of the lecture. You should have learned from this lecture that patients with colorectal carcinoma typically present with change of bowel habits or bleeding the rectum or even accidentally discovered anemias. Um, Gold standard for diagnosis is colonoscopy and biopsy. Tumor markers are essential prognostic tests, and rectal cancer is best evaluated or staged with EUS or MRI pelvis. Thank you guys. These are my contact numbers, and we'll see you around, inshallah. Thank you and good luck.